Okay, hi everybody. I'm Michelle Joyce. I am a PT at Plymouth Bay. I'm gonna be 3 years there in January. Prior to that, I spent 22 years at what was Jordan Hospital, is now BID Plymouth, and I see a lot of familiar faces from back in the day, so it's good to see y'all here. So I'm here to talk about high fives. They're important. They can happen again after shoulder surgery. So, I started my education at the University of Maine. I played softball there for 4 years, had a blast, lots of high fives. Then I went to BU twice. I went to get my master's in PT, then I went back for my doctorate PT, and then I taught in their traditional doctorate program for 3 years. And I am the proud mom of 2 Eagle Scouts, and I'm a Scoutmaster myself, so a lot of fun. So if I do this right, you guys are gonna understand the basic principles of shoulder rehab. You're gonna understand the importance of the scapulothoracic joint. It's in quotes because most people don't think about it when you talk about the shoulder joint. That's all I think about. That's the #1 thing that's gonna help your shoulder get better. If you don't have scapular stability, nothing else is gonna work, but we'll get to that. I want you to understand the general rehab principles, range of motion and strength progressions, because that's what it boils down to, and understand the changes in rehab approach based on what the surgeons do to your patient. So the goal of this whole thing is so that you can better understand the shoulder complex and how different surgeries are gonna affect that complex. People say it all the time, shoulders are complicated. Patients say it to me all the time. Colleagues say it to me too. And I just say to them, yeah, they're really complicated, but that's what makes them awesome, because they are the coolest joint in the whole body. They could do more than anything else. And I will argue with anybody who says different. So what you gotta understand is the shoulder joint versus the shoulder girdle. The shoulder girdle is actually 4 joints. It's scapulothoracic, which is my favorite, the glenohumeral, which everybody talks about as your shoulder, and then acromioclavicular and sternoclavicular. Not a whole lot of people talk about them. They don't go bad often, but sometimes they do. And dysfunction in any 4 of those joints is gonna lead to a shoulder pain referral for us as PTs, and then it's our job to figure out, okay, where is the problem here? All right, so we're talking about high fives tonight. And so this is my daughter, Molly, and her teammate, Mesa. They play volleyball at Bristol Community College. They told me I could use their picture if I gave them a shout out, so there you go, ladies. They high five constantly. I don't know if you know volleyball, but they play best 3 out of 5, 25 points. They high five after every point, sometimes multiple times. So they know about high fives. So the components of it, what do you need to get to a high five? You need range of motion and you need strength. And you need strength in your scapular stabilizers. It's first for a reason. Your rotator cuff, your biceps, your triceps, and then your big movers, the ones that everybody else thinks about, your deltoids, your lats, pecs, traps. But if you remember nothing tonight, remember happy scapulothoracic joint leads to a happy glenohumeral joint, leads to high fives. You cannot start at the glenohumeral joint and expect to get the high fives. It's just not gonna work. So my colleagues talked about the rotator cuff. I'm gonna talk to you about like what does it do, you know, why do you care about it, how does it work? And if anybody's ever seen a crane lifting stuff up, if you haven't, I highly recommend it because it's fascinating. But they have this big crane lifting up an I-beam or a big panel or something like that, right? And sometimes, if you're lucky, there's a guy that's just holding onto a rope. And it's a tiny little rope, and you're like, what is the point of that? And it's really the whole point of the whole thing, because if that big crane lifts that thing up, it can spin out of control, right? If the guy with the tiny little rope isn't standing there. Same thing with your rotator cuff. That's exactly what it does. It keeps your big movers, your pecs, your deltoids, your lats, your traps, they're gonna move your arm, they're gonna lift your arm. Your rotator cuff keeps everything in, and it keeps it from spinning out of control. So, you got your supraspinatus, the glory hound of the rotator cuff. Everybody talks about it, right? Really only because it's in a bad position. So if things are going bad, it's just gonna get smashed up against your collarbone. But it needs your teres minor to balance itself so that you can get that spin move going. And then your infraspinatus and your subscapularis keep it from going forward and back, right? Because your shoulder is not like your hip, which is a big old socket and a ball that goes in it. Your shoulder is a giant ball and a tiny little socket. So it needs that rotator cuff to hold it together to be able to let the big movers move it, right? So I tell my patients it's a ballet. And if somebody doesn't hit their mark, somebody's falling on their face and everybody gets cranky. And we don't like cranky. You don't forget about the long head of the biceps and triceps because they also can cross the shoulder joint and they can act as stabilizers too, so they get into the play as well. So how are we going to restore high fives? Everything post-op comes down to two things. It comes down to range of motion, comes down to strength. Range of motion is going to be your primary initial goal after surgery. You don't want people to get adhesive capsulitis. It's a nightmare if they do, so you're best to try to avoid it if you can. And it also allows time for tendon and tissue healing. I tell my patients, this is going to be a long, boring journey, but if you stick with me, you're going to be happy at the end. And I tell them, and I'll give you a high five on the way out. So strengthening, you're going to start with, obviously, active assistive. You're going to move to active and isometrics before starting resistance. That shouldn't be news to anybody. But you want to always, always, always begin with scapular stabilizers before you do anything with the rotator cuff. You need to make sure your base is stable before you start building your house. And luckily, strengthening is a lifelong pursuit. The SAID principle is a foundation of exercise science. It's a fancy way of saying if you don't use it, you lose it. For those wondering, it's specific adaptation to implied demands. So if you do this all day and you ask your arm to do this arm will get very strong at doing that. This arm will not. You look a little weird, but that's what you asked, right? So what you ask, you get. And strength will come and go over time. I had a lady, she was wicked cute. She had a rotator cuff injury, and she said, I'm old, I should have pain, I'm 80. And I kept saying to her, you got pain because you're weak. It's not because you're 80. And she did her rehab, she got better, she got stronger, pain went away, she was super happy. I went to discharge her and I said, I got one question for you. And she said, what's that? And I said, are you still 80? Because you have no pain and your shoulder's strong. And she slapped me, which 80-year-olds can do. But people are so conditioned to say, I'm old, I got pain. Not the case. You're old, you got pain because you're weak. And being old is a privilege denied to many, so don't use that as an excuse. So surgical considerations. In 2019, the systematic review is done that there was no consensus at all in post-op protocols for shoulder surgeries. So what that means for us is you got to communicate with the surgeon. You have to get their specific protocol. There's two main surgeons at Plymouth Bay Orthopedics that do shoulder surgeries. They have two different sets of protocols. So for the remainder of my talk here, we're going to talk about this guy's protocols. Walter Stanwood, he wanted to be here tonight. We were going to do a tag team thing too, but he had other conflicts. So we're just going to talk about his protocols. But Dr. Reitmeyer has protocols, and Dr. Stevanovic does some shoulder stuff. He has protocols. So very important, get the protocol of the person who did the surgery. Very exciting news, we just updated Dr. Stanwood's protocols, so they're going to look a little different. And I hope they make a little, make sense and progressions, and you really enjoy them. We worked hard on them. So the ones I'm going to talk about real quick, we're listing as low to high impact on high five. So the easiest thing to get a high five after is a subacromial decompression, followed by a rotator cuff repair, followed by a total shoulder, and then the big daddy of them all, the reverse total shoulder, which is super cool, but we'll get that in a minute. So a subacromial decompression, there's no tendinous repair, so there's not a whole lot of delay. And really what I'm hoping you get out of this is just the comparison of time frames, because they're going to be on the protocols. But a subacromial decompression, you can start doing active assistive at 3 days. So they'll probably be doing that before they even come see a PT. And then active range of motion at 2 weeks, where you can put a weight in their hand at 6 weeks. Everybody wants to put a weight in their hand. And that's what every patient's waiting for, is getting that weight in your hand and moving things. Unfortunately, everything else takes a lot longer to do that. Not a shocker, you should start with scapular stabilizer strengthening, right? So you got to have a stable base before you build your house. I'll say it enough, it'll stick, and you guys will be aces at it. So rotator cuff repair, usually a supraspinatus tendon repair, because it's just not in a great place, and it's the one that gets bashed up the most. But sometimes your biceps tendon the long head of your biceps gets shredded up a little bit, so it crosses your shoulder joint. They just take it off the labrum where it crosses, and they stick it on your upper humerus, right? So you can't flex your elbow for 6 weeks, because they stick it on here, it's got to heal there, right? So you do this. Sometimes people who don't listen do this. They hear a pop, they get a pain, they get a giant bruise down their arm, and they say, I don't know what I did, but when I go like this, I got a big bulge right here. And I say to them, well, Popeye, you have a Popeye deformity, and you blew your biceps tendon off where they stuck it, and that's, that's what you got. And, most times they don't reattach them because they're very likely to pop off. So I tell people right away when they come in with a biceps tenodesis, unless you want this to happen, do not do that. Behave, 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 behave. And for some people, it's easier than others. Active assisted range of motion, just comparatively, a small or medium tear, you can do that 1 to 2 days post-op, but you get a large tear, now it's 6 weeks, right? It's a month and a half before you can do that. Active range of motion for a small tear, 5 weeks you can do it. Large tears, it's 2 months. And people sometimes aren't prepared for that. So day one, I kind of set the standard, I show them the protocol and say, look, suck it up, it's gonna be a while. But if you stick with me, it'll work out, we'll get there. And then you don't get that weight in your hand till 10 or 12 weeks post-op. You let everything heal. It's not as big a difference there. I tell a lot of my patients that just can't stop and they push and push and they want their sling off and they want to move. I tell them you can be saved by a sock. And I tell them to put a sock on their hand. All right, those are some sock puppets I made for a scouting event. But a sock can slow your mind down. So if it's somebody that's just pushing, I say to them, just put a sock on your hand. And they look at me like I'm crazy, and I nod and say, yeah, a little bit. But if they're doing things at counter level and they're just bebopping, they're doing their thing, with a sock on your hand, you go to reach and grab that gallon of milk, you're gonna reach, your brain is gonna stop and go, what is that? And it's gonna stop you enough that you don't just grab that and lift it. Because I've had plenty of patients say, I wasn't thinking, I grabbed that and it hurt and I hope I didn't screw everything up. So those people, I tell them, just put a sock on your hand. It'll save you a lot of heartache in the end. And it works. So total shoulder replacement, that's gonna dislocate you in what I call the chicken wing position. It's abduction, external rotation. If anybody's ever broken down a chicken, that's how you pop chicken wings off, right? I tell my patients that too. Some appreciate it, some don't. But some personal hygiene maneuvers are gonna be difficult. They're gonna be risky, and you don't want them doing it for 12 weeks. So anything armpit related, deodorant, shaving, you gotta, my OT friend here, Tammy, you gotta lean this way and get in there. You can't do it this way. Washing your hair, you kind of wash your hair like this. Getting shirts on, you put it on the injured arm first before you put it on the other. And most people figure those things out, but when you tell them, chicken wing, they remember it. It involves a subscapularis repair, which comes from underneath your shoulder blade and comes this way. So if you rotate out this way, this thing's gonna pop off and it's gonna ruin everybody's day. So there are limits on rotation that you don't wanna go past 30 because you don't wanna put tension on that newly stuck down tendon and have it blow, because it's not good, it's not pretty. Knock on wood, it hasn't happened a whole lot that I know of, so we just be super careful with it. Passive range of motion 2 weeks with limit range, active range of motion 6 weeks, so it's a month and a half before you can lift your own arm up. And you don't get that weight for 3 months. And I tell people it is not gonna be fun and interesting for 3 months, but I am fun and interesting, so we'll get there. So reverse ball and socket, right? Super cool. You need your ballet, you need your shoulder, right? You need your ballet to happen. You don't have a rotator cuff anymore, right? So you're like, oh, I'm doomed to do this for the rest of my life. You are not, because some genius somewhere said, let's just swap it, right? So they just flip it, and now it's a hinge. And it's no longer a ballet, it's just a hinge, which just makes it so awesome. It's really a cool thing. So that dislocates you here. Some people politely call it the shirt tuck position. I call it the you did something wrong and the cops are coming for you position. But there are also personal hygiene issues to think about, right? You can't get your bra on, you can't wash your back, tucking in a shirt, getting a belt around you. You gotta put the belt on before you put the pants on. They have to avoid those for 12 weeks. These guys are not gonna get full range of motion, so they can still get high fives, but they're kind of down here, they aren't up here. And a goal is 130 degrees of flexion. If they get that, I tell them you're technically a surgical success. Some people get a little more than that, but it's as tolerated. Again, active assisted range of motion, a month and a half. Active range of motion, 6 weeks. And no weight in your hand for 12. So, if you remember nothing else, as the level of rotator cuff or glenohumeral disruption increases, the restrictions on your patient are going to increase. The timeline to get that high five back is going to be delayed, but you can get there. Any immobilization is going to weaken your scapular stabilizer, so if they're in a sling or they're splinting their arm, your shoulder blade's going to get weak. It's just going to happen. So that's where you start when you build it back up. Protocol should be provided by the surgeon who did it. Don't pull something down on the interwebs and say, hey, I got this, because it's probably not going to be what they want. Post-op high fives are possible if you come at it from the right the right direction, you build that house in the right order, you can get them there. So don't give up the dream of getting high fives for your patients after shoulder surgery. So I hope you guys can help keep everybody celebrating.